recording. This is exciting. All right. Welcome, everyone. This is the Eviva podcast. Welcome, Dr. Tan version.
Hey!
We have Dr. Mimi Tan with us. She is our newest bariatric surgeon to join Eviva, which is very exciting. So I'm Dr. Brandon VanderWel. We have Dr. Robert Landerholm here as well. And today we're going to just we'd love to get to meet you, Dr. Tan, and, just get to know you, how you kind of joined our practice, what got you into bariatric surgery, a little bit about yourself, all that good stuff. So without further ado, so you joined us in October. So you joined us early this month, and you just came from, tell us a little bit about yourself, like what your education was, how you landed here.
How I ended up here. Yeah, well, I grew up in the Pacific Northwest. I was actually born in Utah, but pretty much have grown up my whole life in the Pacific Northwest on the east side. And then went to the University of Washington for undergrad. Go Dogs.
Go Dogs.
And then go Dogs.
Sorry, Rob.
Sorry.
You know, I paid them a lot of
Dogs
tuition also.
Yeah.
And then I made my way to Ohio. Well, I took a year off after undergrad, traveled, and then took a year off, went to Ohio for medical school, the Ohio State. Whenever I don't say the, people correct me. So the Ohio State.
Yeah.
And that was fun. Had a good time there, but then wanted to really come back home for residency. So I ended up at Swedish in Seattle for general surgery residency. And then I went down to Portland for fellowship. And now I'm back again in the Seattle area. Hopefully not moving again anytime soon, although I'm looking for a house right now, which has been an interesting process.
Yeah,
but
it's interesting.
One of the things
probably have to move
interesting
again.
is all three of us went through the Swedish residency
I
program.
know. We have our entire
common.
surgical cohort is Swedish grads. So.
I know, we're Swedish bred and born.
Yeah, no, Swedish was a great place to do training and just a fantastic experience and great surgeons to work with there. So.
Broad spectrum of opportunities to do surgery. With some excellent surgical training.
Yeah. And so you probably trained under some pretty incredible chief residents during your time out there.
Not that you can recall.
Well, it's funny. Yeah. Well, so, I ended up here, I would say mostly because of you, Brandon. So I remember I started my intern year and Brandon was my chief at that time. And for those listening who don't know kind of that hierarchy, your intern is your first year of residency, and you've literally just finished medical school and you don't know anything. Like you don't know how to dose Tylenol. Like I don't think I knew what an NG tube was. Not really. Like I was
too so enthusiastic though. It's wonderful. It's such a special time. Yeah.
Yeah. And so you were my fearless leader through all of it, And
I think another common thread is the enthusiasm.
So much time with you.
Yeah, we did spend a lot of time. We spent
a lot of time together.
No, it was really good. So, and that's where, we always look for, whenever we're looking for people to hire, I think, especially in a private practice setting where we do a lot of ambulatory bariatric surgery, having really quality surgeons is critical for getting good results and for having patients do well and for, keeping the complication rates down. And our complication rate is really excellent. So we've always have on our radar that, talent that we have already identified and
And I think I mentioned this to you too, Mimi. One of the first things he said, maybe 2 weeks in after he joined me in 2019 was there's this person named Lancey. And I was like, what kind of name is Lancey? But he said, he identified you early. He said, this is a person of potential. Little did I know, I think that was just your first year of residency, right?
I can't imagine I was impressive.
Well, it was second or third.
There you go. But that was it. He identified that early and we kept in touch through the years as things played out. And here we are, fast forward 4 years later.
Yeah.
I think finding a good combination of surgeon is like, I don't know what the hand-eye coordination aptitude, right? And there is a certain baseline, whether you got it or you don't. And by the time you're like in your late 20s was when you start your residency, like for most people, like there's either something there or there's not. It's hard to develop that late if you have none. And then from there, it's just like, as long as you have a baseline and an adequate baseline, you can do a lot with that. And especially when people are hardworking and they're invested in their own education and building their own skill sets, and they care about people and they're really nice to people and they're easy to get along with and work with. It's like, that's all the things you're looking for. So.
Well, I think there's one more thing there though too. And you touched on it a little bit. It has to do with the personality and the mindset of the surgeon. I mean, the technical aspects are absolutely essential, but knowing when to operate, knowing when not to operate, and being able to tell the difference, and then bringing your surgical acumen to that, and also having a personality that can meet a patient where they are in taking potentially a complex medical situation and breaking it down into terms where the patient goes, you know what, I get a good understanding of what's going on here, and I trust you to take care of me. That's huge.
Yeah. I think that's something that we don't, like, historically, we have not valued as surgeons. You know, the surgeon stereotype is like, you need to be hard. You're kind of not a very nice person.
Yeah.
You know, maybe you're not very nice to your patients. Like, there's a lot of negative things that are associated with being a surgeon. And I feel like that's really like been a negative thing for our profession, honestly.
Mimi, can I tell you a story?
Yeah. Yeah, of course.
After my first year of residency, I actually did my first 2 years in Portland at Emmanuel, then came up to Swedish for my third, fourth, and fifth years to complete my surgical training. But at the end, I think I've shared this with Brandon, at the end of my first year of training, you get reviewed by your chief of surgery, right? So there you are sitting across the desk from this, imperial person who is your director, holds your professional life in their hands. And he's like going through my portfolio going, okay, surgical skills, on par for level of training, knowledge of, basic science and surgical problems. Yeah, good. But there's one pervasive, observation or complaint about you. I was like on the edge of my chair. It's like, what? And he goes, you're too nice. I was like,
oh, the hammer's down. You're hopeless. Yeah.
I was like, so what do I do about that? What textbook can I read to unlearn that? But you're right, Mimi. You're right. There is. Surgeons also have a reputation of being a hammer looking for a nail to hit. And so being able to bring the humanity into it, in a kindness, in an understanding, and an empathy, and ability to walk people through potentially scary and complex situations. It's hugely important in what we provide.
Yeah. Well, I think that's so funny that you said that, because that is actually the feedback I got all through residency and then fellowship as well, that you were too nice. And I'm like, I don't know what to do with that.
Well, I
don't think I'm going to change it. I'm just going to keep being nice to people.
Yes. That's the paradigm of what surgery can and actually should be. There should be a kindness factor in it. Yeah.
And especially in private practice, like in a practice like ours, where, one of the biggest reasons we're here is like, we all want to deliver really good, like essentially customer service. And customer service, essentially like the baseline customer service, is so absent from a lot of medical practices in general out there. And I think all of us have been frustrated at that on some level. And it's just really nice to try to be nice to be nice to your patients personally, right? You can't, but also have a potential to enact on your system of like, hey, how do we have this be a really good experience for the patients? So.
Well, I think we've really emphasized that the last 4 years, Brandon, that we've been together. We want to bring that humanity to it. There's nothing like being a patient, which we all will be if we haven't already. But, imagine trying to call an office to make an appointment and you can't find somebody human to talk to.
Yeah.
Or you've got a simple question. And that's one of the things we want to provide, and we are providing. We want to be responsive to people's needs. And if that's not meeting their needs, we want to listen to them so we can actually make things better as well. But the fundamental our ethos is we want to take care of people the way we would like to be taken care of.
Yeah.
So I want somebody who's technically excellent. I want somebody I kind of like, somebody that we can have a professional, positive experience with, and that I feel I'm being heard.
Yeah. And also someone who doesn't think that every nail needs to be beaten down with a hammer.
Exactly.
Because it is true. It's very important that you understand, like, all the breadth of options that are available and the risks and benefits of all those things and kind of what that means for patients.
Yeah. And I mean, I think that's so important in bariatrics in particular, right? Because we don't just operate our patients and never see them again. We see them for the rest of their lives, potentially, right?
Yeah.
So like when people ask me, how do you pick a bariatric surgeon? I say, well, your surgeon's one, like that's important, but actually who is the entire team who's going to be following you forever? Like, are they people you want on your side? Because you're going to need them.
Yep.
Right? So
it's very true. Speaking of that, how'd you get into bariatrics? Like, how'd you, when were you kind of like, I want to be a bariatric surgeon?
Well, it's funny that you asked that because, it's a whole story.
Once upon a time in a faraway place.
Yeah.
Exactly. It all started one day. I started medical school, and when I remember when I was interviewing for medical school, I told everyone, well, I want to be a family practice doctor. I want to follow my patients long term. I want to be their like lifelong doctor, go through all their ups and downs, make them better people, healthier people, blah, blah, blah. And then I got to medical school and I spent some time with the family medicine doctors, and I just didn't really love the day-to-day. They're very busy. They have a lot on their plate. And I was just like, this is not really what I see myself doing. And I ended up looking at surgery. I love surgery. Being in the OR was just so fun.
Yeah.
I have a question for you, Mimi.
Uh-huh.
So what surgeons in your life were different enough that they attracted you to that specialty? Because clearly you must have worked with surgeons that you liked.
Yeah, well,
or not.
Honestly, I did like some of the surgeons, but my overall impression was like, this is a tough place to like hang out,
Yes.
It is a little tough, but I think like what makes surgery so cool is it is a team environment. It's a team sport and it's a performance sport, right? You're like in there and every day when you show up to the OR, you have to be 100%. You have to be your best. You have to aim for perfection.
That's great. And
it's a lot of pressure, but at the same time, I like trying to be perfect all the time in the operating room. And so it was super appealing to me. And I had a lot of people say, don't do surgery, I had a lot of people say, go do pediatrics or whatever. But
so you were
whatever. I'm just going to go do surgery. It's okay. I'm just going to try it out.
Well, it's so funny. It's so funny because I think your experience is wonderful and kind of different than I would anticipate, because a lot of times people identify with a mentor and then they kind of follow in that pathway. I got sucked in by really nice surgeons that I worked with, and then
you got suckered, huh?
How brutal it could potentially be. But you mentioned pediatrics. I thought pediatrics would be cool too. My rotation at Children's Hospital moons ago was the most brutal senior resident I'd never ever worked with. It was unbelievable. It was a pediatrician, and they weren't nice. And I couldn't see myself as like, well, I can't do that. So you were able to see past the personalities to something that had potential for you.
Yeah. And I mean, I think it's unfair for me to say that there were no nice surgeons in my life. I don't think I would have gone into it if there were no nice surgeons. No, I mean, I still had mentors along the way and they were wonderful. But, I think it's everyone has a moment when they're in med school and they become a surgeon because they have that moment where they're like, this is really for me, because everyone's going to tell you to not do it. There's a lot of things that detract you from becoming a surgeon.
Big time.
But you end up saying like, well, I really want to do this. Yeah. So I started residency, and then honestly, I don't think I knew what bariatric surgery was when I started residency. And I can't say that I like fell in love with it immediately, because just like during general surgery residency, you do everything. And a lot of it is so crazy. Like you're doing trauma, you're doing transplant, like cardiac surgery, like all these crazy things. So it takes some time for you to just absorb it all. But eventually I started really thinking about, what do I want my life to look like? What do I want my practice to look like? What do I want my patients to be? And that actually excluded a lot of different specialties that I could have picked. And bariatrics was something that was still kind of on the list. So I started spending more time with the bariatric surgeons at my residency, and I kind of just like slowly fell in love with it. Like the surgeries are amazing, right? The surgeries that we do, they're so like, they're just wonderful surgeries to do, and they're so effective. But really the patients are what I fell in love with, working with the bariatric patients. I think bariatric patients are some of the best patients that you can work with. And I think it's rare in medicine that you have a patient that comes to you almost purely by choice.
Yeah.
And a choice to make your life better, right? They come to us saying, hey, I've made a decision where I want to change my life. I want to make my life better. And if you already have that attitude, like everything's kind of easy. It makes my life easier. It's so much better. It's so special. So it's just an awesome place to be. So I like to say that we do primary care and we do family practice care through surgery.
I think you're absolutely right. I'd be interested, Brandon, in your experience as well. But like you, Mimi, I thought primary care is where I was going to go as well. And but and that's the thing I missed doing general surgery for years, is you don't have that long-term relationship with patients. You meet them once, you operate once, you see them post-op, and as long as everything's going well, you never really ever see them again. And then it was really interesting, and I didn't like that. I like the continuity of care in primary care, but like you, it wasn't exactly what I was looking for. So in bariatric surgery, we've kind of hit the sweet spot, because we get to see patients over time and really make things better. So it's very unique.
It's very unique.
Yeah, that's what's so cool about bariatrics. I mean, I'd say all of us probably get into surgery because we love fixing things. We love to perform. Like, I remember doing I got into surgery. Like I thought I was gonna do primary care too. When I went into medical school, because my mom does family practice and all, and that's like most of my exposure was that. I loved it. And I like getting to know people and helping them and helping their lives be better, and kind of some of the other coaching and things like that about, all the other things that aren't necessarily a pill or something like that. But then as soon as I did my first, we do at Loma Linda, where I did my medical school, we have this couple weeks where you do like 2 or 3 weeks of like some sort of specialty beforehand, before you even start medical school classes, and you don't know anything, right? And they just throw you in there and like, hey, just check it out. Have some random experience. And I did neurosurgery, and it was amazing. I was like, oh my gosh. I mean, first day of school, we're like taking off someone's skull and working on their brain. It was the wildest thing I'd ever seen. And I was like, holy cow, surgery's incredible. And then doing anatomy, like in the second week of medical school, we're doing dissecting cadavers. And I was just like, I have to do this. I love this. And the anatomy professor's like, Brandon, you should do surgery. So, just because we were just dissecting all this cool stuff. It was really, really cool. And then from there, it was just like, I mean, I couldn't imagine myself doing anything but surgery. But then when you get into surgery, like especially general surgery is really cool, because you get to really work on a lot of things that are life-changing for people and life-saving. And I love that about general surgery.
Yeah.
But you just feel like you're playing defense.
Yes.
Like, you're just
putting a Band-Aid on.
You're just all you are is a goalkeeper. And it's just like the only thing you can do is just hope you don't screw up so you don't lose the game for your team. That's what it feels like. And bariatric surgery is like the one specialty in surgery where you feel like you can score the goal, right, and win the game. And that's what, like, when I started seeing that with bariatric surgery, it's just like, man, these people come to you because they want to make their lives better. They want all the things that I got into medicine for, right? I became a doctor to help people, to make their lives better, not just fixing problems is a big part of that. And that's what a lot of medicine is. But there's so much more that we see that, like, so many of the issues that we deal with in general surgery are downstream of people's health. And number one on the problem list of people's health is obesity. And, and when you see people like dramatically improved with the very cool operation, you're just like, man, this is cool. And personally, I like the hand holding that comes with bariatric surgery. There's a lot of relational parts of it. There's a lot of, getting to know people. And I think that's what, I think all of us love that part, is that you get to have that long-term relationship, and you get to have that meaningful impact on things that aren't just like a pill. They're not just a surgery. But, I think all of us will see that, in the one you see that like years out from surgery, the best part of people's lives is the stuff that's not even scale. It's not even the other things. It's like, hey, what I feel, I'm empowered to live a better life, and I'm healthier, and I'm just feel so much better about, and I can have a plan for, living in a healthy way, and I'm executing it. So,
yeah.
Rob, how did you wander into bariatrics since because you were doing general surgery for a while and then got into it? So
yeah, that's its own kind of interesting story. And just listening to what you were saying, Brandon, I just kind of want to just kind of add on top of that. I think one of the things that's so wonderful about what we do is the inspiration we get from our patients.
Yeah.
I mean, I like to say, we've talked about this before, we almost get to live vicariously via their success.
Yeah.
And it's interesting because we end up, it makes us feel good, right? Like we've made a difference, but it's them, right?
Yeah.
And it's so wonderful because they thank us, right? They think, thank you for making my life better. Thank you for saving my life. And I like to say, well, we can't do it without you.
Yeah. I know.
Right. So how did I get into it? It was very interesting. I was, very, very busy general surgery practice. Really just classic old school surgery, thyroids to hemorrhoids, like we like to talk about and joke about, and a great diversity there. And I was introduced to the subject about 20 years ago as a possibility, but it was something I wasn't interested in really at all because my experience was the dark side of bariatrics from, experience 30, 40 years ago, where it was unstandardized open operations, and it was the Wild West of bariatric surgery. And there seemed to be some good results, but the complication rates just seemed to be so extraordinarily high. So I remember working at Swedish, working at Harborview, and one of the jokes was, if you couldn't get a job doing regular surgery, you could always be a weight loss surgeon because it was just fringish. And I just wanted to take care of the complications of patients. So fast forward to 20 years ago, and Back to the Future, and we started doing lap bands, and I wasn't that enthusiastic about it. I was like, I can support doing that. I mean, I'm always willing to be open to new technology, something that might make things better. But it was nice because it was laparoscopic. It was minimally invasive. It was same-day surgery. Mm-hmm. And it's like, wow, these patients with bands, at least initially, did really well. And all of a sudden, the light went on. It was like, there's something here.
Yeah.
It's nascent. We don't understand it. And then you come to find out the lap band didn't seem to be durable. There's a certain small percentage of patients who do well long-term, but there were other options. Old-fashioned gastric bypasses started doing them laparoscopically, right? We were the first in the world to do that on an outpatient basis in 2008. 2007, perfect storm, vertical sleeve gastrectomy. And I will tell you, going from bands to do vertical sleeve gastrectomy as an outpatient environment, within 6 months, I could see the statistical difference in the patient's experience with regard to weight loss, resolution of diabetes, improvement of all their other comorbid medical conditions. Like, wow, there is something here. We don't understand everything that's going on here, but this has so much great potential. So I slowly ebbed away from doing general surgery to fully committing to metabolic and bariatric surgery. And it's just been the most enjoyable, personal, professional endeavor. And to be able to have an opportunity, Brandon, I mean, hats off to you joining me 4 years ago to even take it to the next level. And then having an influence on Dr. Tan to come join us. It's kind of like, this has just been a great ride.
Yeah, no, I think bariatrics is it's a really unique, it's not for everybody in medicine. I mean, nothing's ever for everybody, but like it takes a certain subset of people to be interested in that. So Dr. Tan, what are your kind of like, what's your sort of approach to patients, and kind of what are your sort of your dreams, I guess, for what you want bariatrics to be like, or your practice to be like, or things like that?
Well, I think...
Is that vague enough? Is that a vague enough question?
It's a very vague question.
Can you make it a little bit more open-ended?
I was just going to make it my own.
That's right.
Yeah, that's probably just
What are,
fine.
what are
Be
your
like a
hopes and
politician.
dreams?
Yeah.
Just answer the question that you want to answer.
Well, I think my hopes and dreams, I might seem small. I don't know if that's the right word, but I just want to be a partner to my patients. I want them to feel good after they leave talking to me or talking to anyone on our team here. And I want them to feel like that they have people that are on their side. Right. Yeah. And I think that's actually like really hard because we talk to our patients for about an hour, maybe 30 minutes even. And it's a lot of information that we're kind of throwing at you during that first visit or every visit afterwards. Mm-hmm. And I think it's just creating an environment for patients where they feel comfortable with us. Because inherently being in any sort of medical facility is going to be uncomfortable. Mm-hmm. And so that's my first hope. And then I think just growing that as much as we can. I think Eviva has been a very exciting place to be. I just started like 3 weeks ago, and it's made me really think about some of the possibilities that are out there, I guess, for medical care. Because, last 10 years, I've been in various medical institutions, but all these medical institutions have there's a limit to what you can do, I think. And there are things that my friends, my family will complain about when they seek medical care. And they're like, there's nothing else now in the 21st century where we're still doing these things. We're still limited by X, Y, and Z, right? Like pricing is so not transparent. It's so inconvenient to find your doctor, make an appointment, do all of these things. And the medical establishments have done nothing actually really to make any changes. I think they're just so big.
It's true.
And Eviva is super exciting because I feel like we are a couple years ahead or even several years ahead of the curve, right? We're doing so much to try to, again, make pricing transparent for patients, make everything easy for patients to go through. We offer telehealth, you don't even have to leave your house. You can still work part of the day. All these little things that make seeking medical care so hard and so frustrating. It's super refreshing to be in an environment where you can do that. And so I think it's really exciting. I think there's a lot of growth there. There's a lot that we can do to kind of make this a better experience for our patients,
Yeah, so, absolutely. Yeah. And that's what I think all of our goals is too, is just to make sure the patient experience is really good, and that really helps them do the best that they can too. If they don't have to fight the system, and we're always trying to improve our system. I think that's the way all of us would just want to be treated. So
medical care is such a fight all the time. It is. Right? It's just
cool. Is there anything that you're hoping to add to your practice? What do you kind of see down the road of kind of adding to your practice? Because right now, I don't think any of us really do a lot of SADs. So I think we've kind of talked about that potentially an option of something that is certainly a viable surgical therapy for people. I know you're doing the ESG training right now. With
I was like, that's a leading question.
Definitely is a leading question. So.
Yeah. Well, I mean, like you said, I think the ESG is super exciting, right? It's something that has been on my radar, but I haven't really gotten down to fully doing and kind of starting and adding into my practice.
That's the endoscopic sleeve gastroplasty.
Yes.
Yes. The endo sleeve.
Which, of course, Dr. VanderWel is one of the leaders. Would you say internationally, Brendan?
I mean, in there somewhere. Yeah.
Okay.
So. I think he's being a little shy.
I think he's being, he's being.
I think there's before I would jump into that. I think one of my goals is to get more. We have some great data. We have great data, and we're working on a bunch of publications, and I think really getting our work into the literature to really move the bar forward, because that's the language that other physicians speak, really. And we're really not going to, they're not going to hear what we're saying until we have published data. So, and I think that that's a really exciting part too, because we do have some great data, and I think there's some great opportunities to even do some things that no one's even doing right now. This is gonna be a really exciting time. So,
yeah. Well, I'm excited. Like, Brandon, you've done more endoscopic sleeves than like anyone on the West Coast at this point. So I'm excited to kind of start on that journey. Hopefully I'll be the second.
Well, you did that. You had the model, you had the training this week, and you did a great job on that model. Like, I teach a lot of the ESG courses, the endoscopic sleeve courses, for I don't teach every single one, but many of them. And they do not generally look that good when people start. So that was, especially being your first exposure to throwing sutures and an actual real something. And you did a great job of practicing getting really facile with the device, because I could tell you, like, it was just muscle memory already. And putting those sutures in was really nice. That looked nice. Good. So
it's super cool. It's cool.
Super cool. Yeah, it's super
so cool. I think the possibilities are endless with endoscopy.
It really
is. It's a little, I feel like it's a little, it's heresy for a surgeon to say that sometimes.
Well, I think as a surgeon, like, where are we going to be in surgery in 20 years, in 30 years? Or there's a difference between where are we going to be and where should we be, right? And I really believe that the surgeons should be leading with endosurgical technology and endosurgical skills, because you could use endosurgical skills. Like, if you have a sterilized, endosurgical platform of some sort, you could be doing surgery through that the same way, and augmenting your laparoscopic surgery and giving yourself more abilities to do cooler laparoscopic surgery. Like, if you're doing esophagectomy and you can, like, use some sort of, essentially endoscopic platform that's just not endoluminal, even at that point, going around, that could be tremendously helpful. Getting around lung spaces, getting up behind the liver, getting, tunneling retroperitoneally. Like, there's so many cool things you can do with that outside if you just, are a little bit creative and a little bit open-minded about things. And endoluminally, like doing things like colon cancer and large benign colon polyps, which we still take a lot of colons out for, gastric cancer, gastric lesions of all sorts. Like, there's just so many interesting opportunities for doing endoluminal surgery. And then there's bariatrics, and which we're already doing with the endoscopic sleeve gastroplasty. And I think we'll start doing more endoscopic fundoplications and doing all sorts of cool stuff. Like, there's just, when we think about where surgery is going to be in 30 years, like, if we should absolutely be doing more cool ninja stuff. Like, because that's what laparoscopic surgery is, right? You're using these tiny holes, and like, oh man, this is really cool how much we can do now through tiny holes. And now imagine, like, how much you could do more through maybe even not any holes at all, or through tiny holes in different ways that you just never could have done before.
Yeah. Well, I think it's funny that, like, bariatrics, it's always been a little bit ahead of the curve, right? We're one of the first laparoscopic surgeons. We went from open to lap. Everything's lap now. And then now, like, we're really doing a lot endoscopically. It's cool to think about what's next,
Yeah, that's a good point, actually. Yeah, because Rob, I remember, like, Rob was like, right? Figure a bowel obstruction or something. We should definitely start. I mean, endoscopic is, we got to figure out a way to fix this out endoscopically. And you've seen you just have some fantastic endoscopic solutions or laparoscopic solutions to things that many general surgeons feel very uncomfortable doing. Laparoscopic.
I just remember being at the point of that spear. I mean, when you were talking about gastric cancers, I was the first at the facility I was working with here to do a laparoscopic gastric resection on an 84-year-old guy, and did the lymph node dissection. And let me tell you, the pushback on that, as that patient, that 84-year-old went home the next day, I presented that at tumor board, and it was like, pushbacks, like, you can't do that. It's like, it's going to be the standard of care, guys. Get used to it.
Absolutely.
That's crazy. It's crazy. It's pretty cool.
No, it's super cool. So, and what's cool is that, like, particularly endoscopic surgery, like for gastric cancer, it's not as prevalent in the United States here, but like in Asia, gastric cancer is like.
Yes, their experiences. Yeah,
their experience with gastric cancer is crazy, and there's a lot of people that live in Asia.
Yes.
A lot.
Yep.
So, like, moving that forward, it's such a cool thing to do on so many levels. So Yeah. I know. I think it's a very cool time and a very cool opportunity that particularly that we have at Eviva of doing endoscopic surgery, doing some really cool laparoscopic surgery. I mean, we do some pretty cool revisions of stuff, you know, and like, yeah.
And it's interesting. I think the thing that is driving these, for us anyway, driving the improvement in technique, driving the improvement in procedures that we offer, is I remember talking to that older gentleman, knowing if I did a standard operation on him, his morbidity would not have been insignificant.
Yeah.
And so, in as much as that's true, then you have these options that you can then apply in a way that provides better safety, less morbidity, and greater patient satisfaction. And I think that's, you guys are talking about going into the next 30 years. You're essentially saying the same message. You're just standing on the shoulders of the giants that I've stood on.
Yeah.
Right. And we're building on it. And it's a wonderful, exciting time for us right now.
Yeah. Yeah. For sure.
Cool. Well, any other questions? Mimi, do you have any questions of us?
Ooh.
Yeah.
Oh man. Any questions of you guys? Well, I feel like we covered. You know, every question I've been asked, you guys have answered as well, pretty much.
Well, I think that's what's great about having. I mean, Rob, I think I really appreciate your experience, you know, and just kind of like how we got to where we are at Eviva, how bariatric surgery has kind of come into its own, because you kind of watch the whole things, you know, and we're part of, and a huge part of moving it forward. I mean, Eviva was the first in the world to do an outpatient sleeve and outpatient bypass. And we've been doing, I mean, we have tens of thousands of outpatient cases, you know, and you go and you talk at meetings and people at other places are like, you know, we did some outpatient bariatric surgery and it worked great and it's crazy. And we're like, yeah. I mean, the patient populations are different from a lot of different places.
Sure.
You know, like we have a different patient population than someone, you know, at a bigger hospital probably. But no, it's cool to participate, and it's cool to help and encourage people that, hey, you know, these things are safe. These things can be done well. Here's the keys to doing them. So yeah, it's fun. It's fun. Cool.
There's good news and bad news to being older. There is this thing that does come from experience. I mean, it's the classic surgeon thing, right? What is it? Experience. What do they say? Good judgment comes from experience, and experience comes from bad judgment.
Yeah.
There is this thing about living long enough and having seen how things can go sideways that can actually educate your present to minimize, you know, risk and so forth. But it is, I mean, Brandon, you and I have joked about this before. It's like that line out of Groundhog Day where he says, you know, maybe God isn't omniscient. Maybe he's just been around for a long time. So I can say that I hope I can continue to provide a little bit of color commentary that can make things, you know, better. So, Mimi, and you are the new arrival. And I will tell you, I remember a time in my life when I would sit in a chair and my feet wouldn't touch the floor. And it's kind of like when I started private practice. So welcome. This is a whole new chapter, a whole new thing, and opportunity for Eviva. And we are just thrilled and proud to have you on board.
Oh, thanks. I'm so excited.
Yeah,
it's a new adventure.
It is. All right. Well, everyone who's been tuning in, thank you very much. And you know, we're here at Eviva, and these are our surgeons. We love helping people, and we love taking care of them. And if you have more interest, check out our website, evivamd.com. We have lots of resources on there. You can contact us form. We do virtual seminars on a regular basis that you can tune into, ask questions. So if anything we can do to help, you know, we want to be able to just help patients do well. So thank you again for tuning in, and have a great day.
Dr. V, Dr. T. Hey, guys.
Bye.